Hi, everybody. Thank you for watching. We are going to start our first panel of the day. We've got TSM from the doctor's point of view. Now, I want to introduce our two panelists for this first panel. We've got Dr. Dr Umhau, who I met several years ago at one of the addiction conferences where C3 was an exhibitor, and I have now known John for several years. John has been an enthusiastic supporter of the Sinclair Method ever since looking at the research that first time. John runs alcohol recovery medicine. He's one of our telemedicine providers. He's got an amazing, diverse background in medicine. And we also have Dr. Valsa Madhava. Valsa is also one of our TSM telemedicine providers, and she has an office in New York. And again, I believe we met when we were at an ASAM annual conference or a review course, one of the two. And honestly, to have two doctors of this caliber kick off our first ever conference is such an exciting venture. So what we're going to do is I'm going to let John start first. John, you can give us a little bit more of your background, and then let me know when your slides and your presentation, when you're ready for me to load those, and I will go ahead and pass it off to you. Oh, hold on. It just apparently it unloaded itself. Give me one moment. I'll let you continue talking. I'll let you know when that slide is up. All right, I've got your slides, so. Mm-hmm.
The best thing to do in this talk is to talk just briefly about the nutritional imperative to treat people with any kind of addiction, and then I'll describe the one medicine that is most popular here in the United States called naltrexone. Of course, in Europe they have nalmefene, but in America we use naltrexone. And I suppose if this were watched in Europe, that you could exchange the word naltrexone for nalmefene in a lot of cases, except for the side effects of the drug. So the next slide shows how inflammation can drive the problem with alcoholism. With drinking, first, at number one there, the excess alcohol will alter the gut. It alters the gut microbiome. It causes what we think of as a leaky gut or increased gut permeability. And this allows the dead bacterial byproduct called endotoxin, as well as other toxins, to enter the bloodstream where they'll first affect the liver. Initially, this just causes liver inflammation, but eventually it can go on to cause fibrosis and liver cirrhosis. As the liver is affected by this endotoxin, it develops an inflammatory response that creates cytokines. Inflammatory cytokines are chemical messengers that the body uses to fight off infection. But in this case, they do some harm because when they get into the brain, especially when there's excess alcohol, as seen in number 3 here, there are effects on the brain, and the brain develops an inflammation, as seen in number 4. And this inflammation in the brain is part of a lot of mental illnesses. We see it in depression. We see it in a lot of problems that are associated with the cortex not working really well. The pieces of the brain don't connect with each other really well. So people lose control. Sometimes they experience a sort of a brain fog, or even cell death and atrophy of the brain eventually. But this can go on to make the problem of drinking worse because the brain fog inhibits recovery efforts. And also the hangover symptoms, the inflammation in the brain actually may be relieved by a first drink of alcohol, which has some anti-inflammatory effects. Let's take a look at the next slide here. And this kind of shows how I approach the dietary treatment of alcoholism. To start with, we can improve the diet. There's no medication necessary. We don't need to see a doctor when we just improve our diet, because the diet can really drive a lot of this leaky gut that can cause complications from alcohol. First thing we see is that we have a lot of processed food here in America, and we have very high omega-6 fatty acids and very low omega-3 fatty acids. And I'll talk a little bit about that more in a minute because it's really important. We see a lot of high fructose corn syrup, sweetened drinks. This can cause inflammation of the liver, as well as a lot of things that we don't understand well. We don't know what else is affecting the gut to cause it to leak. But sometimes things like gluten, artificial sweeteners, maybe toxins in the environment, maybe even our genetics or medicines that we take, antibiotics, all these things can potentially affect the gut, and it can make it leaky and allow more of this toxic endotoxin to get into the circulation and affect the liver and the brain. So as you see on the right-hand side, the treatment for this can be omega-3 fatty acids. I recommend all my patients do high-dose omega-3 fatty acids because unless they've been eating fish every day, there's still a benefit to be had from having more omega-3s. I also recommend vitamins, minerals, zinc, magnesium is important, and also probiotics. It turns out that the Lactobacillus GG probiotic has been studied quite a bit, and it can reduce liver inflammation. So let's change slides here and talk about brain opioids. Now, brain opioids are what we think of when we think of what drives addiction. Brain opioids can be very important for driving behaviors like pleasureful behaviors, being with your family, playing games, and so forth. That can drive us to do those kinds of things. But endorphins can also be released when we drink. And this drinking is release of endorphins is where a lot of medications act, particularly naltrexone. Endorphins are released not only with drinking, but with just thinking about drinking. And that's why the first drink is sort of the most powerful stimulus for endorphins. Even thinking about drinking can reduce endorphins as well. And that's probably why craving is increased over time, because the craving actually can release endorphins. But as you might imagine, if endorphins are blocked, then the pleasure can be minimized. Can we have the next slide, please? Which talks about the different medicines which are available for treating alcoholism. We have 3 that are approved by the FDA. We have the disulfiram, which makes people sick when they drink. We have acamprosate, and we also have naltrexone in 2 forms. One, we have the injectable form of naltrexone, which can last 4 weeks, and that's really useful, particularly with people can't remember to take their medicines. And we have the naltrexone pill, which is what the Sinclair method focuses on. And This is also accompanied by other medications that are used, what we call off-label. These are not approved by the FDA for this use, but they are used for other things. For instance, topiramate, which is used for seizures, baclofen, which is used for muscle relaxation, and ondansetron, which is used for nausea, as well as other medicines like prazosin or gabapentin, which can have other more serious side effects, but which can really help people reduce the craving for alcohol. And physicians who study alcohol and how to treat it know about all these medications. So next slide, please. When I think about naltrexone, first I want to think about what side effects you can get from naltrexone. Well, there's a number of things that we can see about naltrexone. Naltrexone is really good, especially for people who have a family history of alcoholism. It seems to work better for these folks. It's an opioid blocker or antagonist. It was initially developed to treat opiate addiction, but only later found to reduce alcohol consumption. Most people can tolerate naltrexone well, fortunately, and the common symptoms such as nausea or headache typically resolve over time and can be minimized by taking the pill with food and fluids. Suicidal thoughts are a rare side effect that requires special caution, and this is why this medicine should really be given under the supervision of a physician. Naltrexone also may require monitoring of liver function because the naltrexone can affect the liver. Now, naltrexone, as we said, also blocks opioids, so opioid pain medicines won't work. People need to remember this, especially if they are in an emergency and they need to get pain medication, say for a broken arm in a car wreck. So that's why we recommend that they carry a wallet card that says that they're taking naltrexone. Another side effect for people that are chronic opioid users or addicted to opioids is that if they take the naltrexone pill, they'll go into instant withdrawal. And this is a really bad situation. So we recommend that people that are on opioids have to stop the opioids for at least a week or so before they start trying naltrexone for alcoholism. A milder but analogous situation to this opiate withdrawal probably occurs in the chronic drinker who's drinking a lot of alcohol throughout the clock, because they have so much endorphin from the alcohol that when they take their first naltrexone pill, it's like going into withdrawal. And that's why sometimes the naltrexone needs to be guided by a physician so that the dose can gradually be increased and the side effects are less and it can be more tolerated. It's important to remember that naltrexone doesn't block intoxication, but actually can impair peripheral vision and cause more divided attention, so driving can be even more hazardous. With daily naltrexone use, the body adapts and the opioid receptors upregulate. And what's really important to remember is that this upregulated receptor situation can stick around if naltrexone is suddenly stopped. So the effect is that people are more sensitized to things that cause endorphin release. Pleasure, or if someone's taking naltrexone every workday, but stops the naltrexone on the weekend to go get drunk, they may find that these super sensitized opiate receptors make drinking especially pleasurable, and that makes it even harder for them to stop drinking. So that explains why compliance is really critical when you're talking about naltrexone. It's not for everybody, because not everybody is able to maintain this kind of compliance. So next slide, let's take a look about how the FDA first prescribed naltrexone. When I started using naltrexone more than 20 years ago, I was working at this alcohol research unit at NIH, and I used naltrexone dutifully following the FDA approved labeling. That is, after someone had been through detox or stopped drinking. My colleagues and I found that naltrexone didn't really work that great. Mostly, people experienced a dulling of life's pleasures when they took naltrexone, and eventually they quit and they would resume drinking. We also found that if people weren't compliant with taking it every day, it didn't work as well. And again, we probably think that what happens is that the receptors would become super sensitized when people quit the naltrexone for a couple of days. And if drinking then occurs, excessive alcohol euphoria could lead to a really bad relapse. Next slide. Well, fortunately, we have David Sinclair's research to fall back on, and this is really cool. This is what Jenny's group, the 3C Foundation, has really been promoting. David Sinclair found that animals who were trained to drink alcohol could unlearn drinking by using naltrexone. And what would happen is that this learned behavior of drinking would be extinguished if the animals received naltrexone before they had each drink. And when Sinclair tried this on people at his research program in Finland, he noted that targeting of naltrexone had a lot of advantages. Not only would people lose their craving for alcohol over time, but they wouldn't get tired of the therapy. They wouldn't have the adverse effects of the blah, dull feeling that people would get taking naltrexone every day without drinking. Instead, Sinclair had people do particularly pleasure-inducing activities on the days when they didn't take naltrexone. And this allowed for the behaviors that were more healthy to take over the effect that alcohol did. It allowed, as Sinclair described, as a rewiring of the brain to move away from addiction to alcohol to, say, addiction to more pleasant, healthy activities. Sinclair also realized that it was really important because this allowed a gradual reduction of drinking over several months without the need for expensive and unpleasant detoxification. And that's really critical for people that can't afford the hospitalization that's sometimes required. Sinclair and people like myself who use naltrexone in their practice also recognize that the targeted use of naltrexone with drinking is extremely helpful for people who are not ready to stop drinking. They would otherwise completely reject help for alcohol use disorder because they're not ready to be abstinent. So let's take a look at the next slide here. This is a graph that I threw up because it's important to understand what's going on when you take a naltrexone pill. Now, the idea with naltrexone is for endorphins to be blocked completely. And the black line in this graph represents blood levels of naltrexone. 60 minutes after swallowing a tablet, naltrexone blood concentrations are at their maximum. And endorphin receptors are completely blocked, and this creates a wall against alcohol-induced euphoria. When a first drink occurs at an hour after you take the pill, this is the critical time because this is the time when the blood levels of naltrexone are probably the highest, and naltrexone is going to have the maximum effect. Now, what happens is that the endorphin release by subsequent drinks is probably not as great as the first drink, and therefore the waning naltrexone concentrations that occur over time may continue to provide an effective wall. However, 4, 6, or certainly 8 hours after taking the naltrexone pill, naltrexone concentrations in the blood have dropped, so a stiff drink or continued drinking can break through this naltrexone wall. Endorphins are released, and continued drinking is reinforced. One thing that's really interesting is the naltrexone FDA label implies that 50 milligrams of naltrexone can block euphoria from heroin for 24 hours. However, the effect on alcohol may not last this long at all. And for a given dose of naltrexone, different people have very different blood levels, and only those with the highest blood levels will receive benefit from the naltrexone. Because of this variability, some people may require a repeated or higher naltrexone dose, and this is why it's important to discuss your therapy with a physician who understands this. Slowly drinking less concentrated alcohol drinks may minimize the need for higher doses of naltrexone. This is really important. Therapy, however, is only informed by the subjective effect of alcohol in relation to the time elapsed since taking the naltrexone pill. Also, some patients find that naltrexone is more effective if they use beer or wine because they're less concentrated. And the rapid effect of a strong drink may not have this same response to naltrexone. Also, if someone is going to be drinking all day, they may need to take another dose. And again, the physician can be very helpful in deciding what's necessary. Next slide, please. So this slide just illustrates a cell phone app that's been created by the C3 Foundation. My patient here recorded their drinks over a period of 23 weeks. And as you can see, the number of drinks per week gradually increased down to almost zero. Persevering through months of treatment, ups and downs can be really daunting. And without frequent encouragement and monitoring drinking like this, many will give up without extinction. One of the real benefits of this seminar today is that people will learn how they can be encouraged to continue with the Sinclair Method through the help of coaches and other helps. Keeping a daily record of drinking can help promote compliance. And what we've found in most people, or about 70 or 80% of people, if they stick with the naltrexone, they'll lose their interest in drinking. However, because alcohol use disorder is accompanied by chronic changes in the brain, even patients who completely extinguish their craving must forever use a naltrexone before they drink to avoid reverting the extinction process. And let's go to the next slide, please. I've had a number of patients who faithfully followed the Sinclair Method to the point of extinction, only to begin drinking after years of really success. There are a number of reasons why I've found that this has failed in my patients. One, probably the most worrisome, is that someone will faithfully take the naltrexone pill. Say, one of my patients was a very accomplished nurse, and she took the naltrexone pill at noon before she went to a wedding. She hadn't had a drink for a long time. She had a drink at 1 o'clock in the afternoon, and no problem at all. But as the day went on and the drinking with the wedding continued, by 4, 5, 6, 7, or 8 o'clock, the naltrexone pill had worn off, and she didn't think to take another one. But by midnight, she was really feeling every bit of the euphoric effect of alcohol. And the next day when she had a drink, she didn't even think of taking the pill, and was back in her addictive pattern. And that's really something that I like to avoid. So that's sort of one of the main reasons why I encourage people to become abstinent if they reach extinction. It's just safer. Another reason why people fail the Sinclair Method is because they may travel and not have naltrexone with them, or they forget to use it, or they run out. And of course, life events that can crush our spirit can really take away our desire for recovery, and people just want to forget and be under the effect of alcohol. And so they just give up. Social pressure for drinking and nostalgia for drinking and the fun that they remember with drinking can also be another reason why people relapse. So I hope this talk has been helpful. If you have any further questions, I have an alcohol telemedicine practice that may be of interest to you. And I think Jenny has some more slides for us coming up here.
Thank you so much, John. Let me go ahead and transition back to, all right, now we're back to the full panel. Real quick, John, before I pass off to Valsa, we had you muted a little bit before the slides came on. So if you can just give people your background real quick one more time.
Sure.
We had a few people that missed that because it's amazing. The sound, you would think with one microphone, you'd have one place to run sound, and I have about 7 different buttons to make sure are all hit,
Sure.
and I missed one, and unfortunately that one was yours.
Sure.
So I'll let you give your background one more time.
Sure. Well, I have been interested in helping homeless guys and people live on the street who have chronic alcohol problems. And I started out as a young doctor, very idealistic, wanted to help these folks. So when I realized that there was really nothing that you could do as a physician for these people, I was really interested in learning about more about what could be done. And so I took a job with the National Institute on Alcoholism and Alcohol Abuse at the National Institutes of Health in Bethesda. And I did alcohol research for 20 years. I worked on the development of new medications for alcohol. And also I was really interested in nutrition and the effects of omega-3 fatty acids and vitamin D and so forth on nutrition. By the way, I'll just say as a little side here, one of the studies that I did was looking at vitamin D in influenza. and coronaviruses. And it turns out that many people are helped by having sufficient vitamin D to help prevent the COVID-19 infection.
Well, that's very interesting. I've seen a lot of different things about specifically about vitamin D come up over the last couple of weeks. So if anyone has any questions about that, we're going to let Dr. Madhava talk, and then we will have time for questions for both of our doctors, and then so get those questions in. You can use the chat function, and then we'll catch all of that at the end. So thank you, John. Dr. Madhava, I'll let you go ahead and talk a little bit about your background and your passion, and let me know when you're ready for your slides.
Great, thank you. Thanks for inviting me. So I'm Dr. Madhava. I started working with addictions right around my residency time, which is couple of decades ago. I was working in a prison, and there were a lot of addicted folks there. People were in jail for addictions. And since then, I've been working with thousands of patients with addictions, both in the jail setting in New York. In my primary care practice, I've worked in methadone programs, and I currently work in a hospital that treats addictions, both detox and rehab. I also have a private practice that treats addictions from a root cause perspective. So over the years, when I was treating addictions, it always seemed to be that patients relapsed over and over again. So I was looking for a different way of treating addictions. So that's how I got into functional medicine. So I'm certified in functional medicine through the Institute for Functional Medicine in Washington. And with functional medicine, we look at the root cause of disease. So my presentation today is looking at the root cause of addictions.
Excellent.
So first slide, I guess.
Okay, we'll go ahead and get those slides up. Okay, so I've got your introduction slide up right now.
I don't see.
You won't. You won't actually see it. Unless you've got Twitch on. Everybody else can see it. But
okay,
you can.
Great. So, all right. So as I said, so the first diagram is shows that addiction is a combination of factors that affects the brain. So it involves the biology and genes of the individual interacting with environmental factors that determines the drug of choice for that individual. Often people use drugs and alcohol as a coping mechanism, but the consistent use of drugs and alcohol changes the brain and leads to addiction. So the biologic factors includes health and nutritional status of the individual. And there are many genes that are implicated in addiction. It is felt that 50 to 70% of the contributing causes of addiction could be related to genes and epigenetics. So the aldehyde dehydrogenase 2 variant is actually protective against alcohol use disorders, whereas the presence of the OPRM or the DRD2 gene variants can make an individual more prone to a use disorder. People with these inherited patterns simply learn that they feel more normal using particular chemical substances. So the environmental factors that can influence or lead to an addiction are considerations such as a chaotic home life, parents' use and attitudes, peer influences, community attitudes, work and school life, social isolation. Additional factors are such as growing up in an alcoholic environment or being abused as a child and being exposed to extraordinary stress, all can contribute to the risk of alcohol addiction. So drugs and alcohol and behaviors such as gambling or shopping are often used initially as coping mechanisms. Drugs and alcohol affect the brain by changing the way brain cells talk to each other, a process called neurotransmission. Drugs and alcohol alter the levels of neurotransmitters. These are chemical messengers like hormones in the brain. There are about 200 different neurotransmitters, And so examples of these are serotonin, dopamine, endorphins. The more drugs or alcohol that you've taken, the more disruptive is your brain. The brain actually changes with addiction, and it takes a good deal of work to get it back to the normal state. So next slide. So you can see here that there are brain changes with drug addiction. So this is a SPECT scan. It measures blood flow and activity in the brain. The left-hand picture shows the normal brain, the smooth surface of the brain indicating normal activity and blood flow. The right-hand picture shows the brain of someone who's been drinking 2 to 4 glasses of wine a day for several years. You can see the holes in the brain, which are areas of decreased activity. So this scan shows that alcohol use changes the brain. And so it's a brain-based disorder. So perhaps talk therapy or peer support alone may not be enough to repair this brain. So this slide shows some of the factors. Oh, sorry, next slide. So these are some of the biologic factors that can contribute to an alcohol use disorder and prevent you from recovering completely. There are many nutrient imbalances implicated in alcohol use disorders, such as hypoglycemia or low blood sugar, deficiencies in magnesium, zinc, and vitamins such as thiamine and folate. These deficiencies could be due to a poor diet or due to poor absorption of nutrients. Acetaldehyde, a metabolite of alcohol, is implicated in creating these imbalances. You need to have enough of the right kinds of nutrients to make neurotransmitters. We talked about genetics earlier. So childhood trauma was measured by the Adverse Childhood Experiences Study, which is one of the largest investigations of childhood abuse, neglect, and household dysfunction. They had 10 questions, which measured each of these 3 categories. Men and women with 4 or more adverse childhood experiences had greater odds of binge drinking and heavy drinking, and they were 7 times more likely to be alcoholic. So you have to address childhood trauma if you have an alcohol use disorder. Next, the metabolite of alcohol, acetaldehyde, is itself a toxin to the body. There are also other heavy metal toxins such as cadmium, lead, and mercury that have been seen in patients with use disorders and may need to be resolved before a patient can get better. As John mentioned, alcohol can cause gut dysbiosis. So the gut influences the brain via the microbiome. The microbiome refers to the microorganisms such as bacteria, viruses, and fungi that live in our colon. They weigh about 3 pounds and are intimately involved in maintaining our health. The gut and brain communicate via the gut-brain axis. There is evidence that drinking alcohol causes change in these microbes. This changed microbiome can produce toxins and can cause inflammation. If you want to have good brain health, you need to have a balanced microbiome. Food allergies can also result from gut dysbiosis and a leaky gut. And these allergies can go to the brain and lead to brain dysfunction. It is estimated that approximately 1/3 of individuals with traumatic brain injuries will drink moderately or heavily after their injury, particularly if they had brain injuries as a child or in their teenage years. Stress can cause overreactivity of the brain and can lead to relapse in alcohol use disorders. Infections such as mold, Lyme, candida are also implicated in alcohol use. Hormonal alterations can also affect brain function and thus lead to dependence on alcohol for mood benefits. Next slide. So there are hundreds of studies that show there's undernutrition and malnutrition among alcohol and drug users. These folks may not have the nutrients needed to make the neurotransmitters, which will promote drug seeking, cravings, and impede recovery. Next slide. My approach to alcohol use disorders is the biopsychosocial spiritual model of recovery. So successful addiction treatment requires diagnosis and treatment of the multiple underlying biochemical and medical disorders. So the foundation of the pyramid is to optimize brain function in order to get complete recovery from addictions. I also use medications such as Naltrexone to help with this process. So patients will continue to relapse until their brain function is optimized. So they will also need good psychosocial therapies and spiritual healing. So it's not just about medications and biochemical balancing. You'll also need all the other supports in addition. Next slide. So that slide is about my practice and a way to contact me.
All right. So we had a question from our audience watching, and John, this one is probably best for you because of your background. What would have to happen for the Sinclair Method use of naltrexone to be on label instead of off label?
Well, that's something that I know that the 3C Foundation is working on. There's a process at the FDA that would have to be undergone so that the FDA is confident that the Sinclair method works. So they have to have some kind of proof that the method works. Usually that's in the FDA where I used to work. You have to have 2 studies to show that a drug is useful for a particular indication, a particular way. Maybe the FDA would require another study. Maybe they'll be able to be petitioned so that they'll simply change the recommendation, but that's kind of unlikely.
Well, that's actually one of the things that we're working on is trying to align things for a label change, but as you said, whether they require existing or new research is a question, along with the fact that they don't do this for free. Usually there are fees and a lot of money involved.
Right. Sometimes those can be waived for good causes, but it's a process. It's very expensive to get a drug approved. That's an issue.
Yeah, and one of the things that we were told by some of our advisors were that we would actually have to mock up the label as we would like to see it changed.
Right.
And then do use studies to make sure that people can understand it and things like that.
Right.
So both of you focus heavily on the value of nutrition in recovery. Are you often faced with any situations where someone says that they're having a side effect that you're actually able to say, well, that's not a side effect, that's actually a nutritional deficit and you can fix it this way? Either one.
Well, I don't know how to know exactly what any kind of symptom is from. Generally, however, if people are not able to be compliant with medications, that's probably because they're not using an optimal diet, and probably because they don't have a good intake of omega-3 fatty acids or some of these other essential nutrients. But it's hard to know when someone has a naltrexone side effect. It's usually pretty obvious that it's from the naltrexone.
Okay.
Yeah. And just in general, I haven't found that many side effects from naltrexone. And in general, I give most patients some kind of multivitamin, multimineral, omega-3 fatty acids. So I think naltrexone in general is well tolerated.
And we've got just a few minutes left already. So I do have one other question. One of our viewers wants to know, it's been mentioned that naltrexone can affect the liver. When you have a patient that comes to you, how do you weigh the effect on the liver from the naltrexone versus the benefits to the liver from reducing how much alcohol they drink?
Well, that's a great question. That's why it's very important to check the liver functions before you start naltrexone, so you know what's going on. Every now and then, someone will have a reaction in their liver to the naltrexone, and you have to stop the naltrexone and let the liver recover. It's possible to start it again. It's really true though that even though the naltrexone may increase the liver enzymes, that in the long term the liver will improve its function because the alcohol drinking is slowed down. So there's very little published data showing that naltrexone is going to harm people through the liver. It's really a very safe drug. And although it can occur, which is why we check for the liver function, it doesn't happen very often.
And I think you can take many nutrients to protect the liver, so that one of the toxins is the liver metabolite acetaldehyde. And there are ways that you can sort of metabolize away the acetaldehyde. So if you do that, you have less liver dysfunction. And so that can also improve function and help you to perhaps use the naltrexone.
Okay, so we're down to 2 minutes left. Let's get one last question in. There are a few here, but the latest one is, so do you see the medical community, your peers, expanding its knowledge and treatment of naltrexone versus abstinence model? How do you see the trends among your peers in acceptance of TSM?
Well, physicians are very slow to change, and they're very susceptible to peer pressure. So it's hard to say how long it'll take to change. However, a lot of my colleagues are highly interested in Sinclair Method. They want to know, does this a better way to treat my patient? And so I think that as the doctors take more interest in the problem, they investigate it, then they'll find out. And I've written several articles to try to make it clear to people that, in fact, the Sinclair Method is a really reasonable option for for alcoholism treatment. And I think that with time, they'll come to accept it, but it's going to be a slow process. I think your efforts to go to the meetings are good and so forth, but there'll be more lectures. I'm trying to give scientific lectures myself to physicians, so they'll get the idea, hey, this is a good way to treat alcoholism.
I think also in general, a lot of like treatment centers have to follow the guidelines. And if the guidelines are not changed, it'll be harder for them to adopt this protocol. But individual physicians can, because we can use naltrexone or any medications the way we think would best benefit the patient. So as physicians are more aware of this method of using naltrexone, I think there'll be more acceptance and hopefully more prescriptions of the Sinclair Method.
Wonderful. Well, thank you both for your incredible insight and your time today. We really appreciate you. Thank you to everyone out there who's watching. I know you guys can't see how many people are on here, but there are a lot of people out there watching, which is really exciting. And I want to thank our presenting sponsor, RIA Health. Again, RIA Health is a large reason why we were able to offer this entire 8-hour convention for free. And our panel sponsor, Deer Haven Gardens. We are just so thankful for our sponsors. We're thankful for our viewers, all of our supporters. If you find this information beneficial, if you think we should do more of this, please go ahead and drop us a donation. And we're going to take a short break, and we will be back in about 15 minutes. So thank you, everybody.
Thanks, Jenny. It's great to be here.
Yeah.